is in international development, went to McGill University, studied that. Really my last semester of college, decided that I would go to medical school. I'm from Maine, went home, did a post-bac, wasn't a real formal post-bac, went on to med school at Dartmouth, stayed at Dartmouth for emergency medicine. In 2016, finished emergency medicine and moved back to Lima, Peru. My wife is from Lima, Peru, and we live here now. So since 2016, I've been here full time. Really over the last 8 years, I've been practicing emergency medicine almost every month, which is not really what I want to do, because I'd like to tamp it down a little bit, but student loans, et cetera, right? Life has done that. So basically I go to Houston, Texas for 10 days a month is kind of the normal thing that I do. Work my shifts in the ER, come back, do med life, go, and craziness of life. Yeah, and so that brings me to now, hopefully gonna get to like 50% ER is sort of my goal. And do more of this. Yeah. So today is Thursday. You've obviously done a whole bunch of stuff. You've done the reality tour. You've done hopefully probably some project stuff, some medical stuff. And I know that some of you have had sort of these professor-led kind of post-clinic activities, and we've done some as well. But that's really what my goal is here, is really to answer any questions that you have and help start to kind of congeal the experience for everybody. And really, again, very happy to discuss anything. We're calling this an AMA talk, Ask Me Anything, so that we can really do something that is of service to you, of use to you, that's helpful to you. I don't want to just kind of sit up here on a soapbox and talk. I would love to talk about things that are relevant to your lives and the kind of work that you're trying to do. So can people kind of holler out? I know there's a whole bunch of schools, but can you just holler out where your school is from? I'm not going to make everybody introduce themselves. Sometimes we do that. It's too big of a group. But can you just... Berkeley? Cool. Berkeley's old school med life. Old school. Knoxville, Tennessee? Indiana? Providence College. Cool. Marietta? NYU? Oh! NYU, did somebody say? Really? I worked hard to get an NYU chapter 15 years ago and was not successful. So that's pretty cool. That's very cool. Anybody else? Okay, and how many of you guys are studying something that is health related? Are you planning on, yep, cool. And how many of that is nursing? Okay, cool, very cool. And then nurse practitioner, PA, kind of mid-level provider? Yep, cool. Doctor-ish, probably, maybe? Yep, cool. And then folks that didn't raise your hand, what are you thinking of doing? Anybody, a brave soul. If you're not in health sciences, where are you headed? Yeah. Global development, that's my background. Cool. Anybody else? All right, cool. Where would you like to start? What do you want to talk about? Yeah, so I mentioned I studied international development. Kind of my background was studying sort of these large, the World Bank type programs, like data-driven, sustainability, all these kinds of things. I think there's an element of me that is just very hands-on, and so in my second year at McGill, I did a program in Panama. And so I did 6 months in Panama that was Canadian professors doing international development, and then we did some internship stuff. And then my fourth year, I did a year in Ecuador through a similar program through a different Canadian university. And then after graduating, I did a stint with Partners in Health. I don't know if that's a name that is familiar to folks. They're an organization that does kind of TB, malaria, HIV work in a bunch of places. MDR TB is what they did here, and that's how I came here. In that kind of transition between undergrad and the post-bac time, I was doing an internship. I went up to a hospital in Riobamba, Ecuador, and I was like, hey, can I volunteer here? And there was an orthopedic surgeon who was cool, and he's like, sure, if you teach me how to swear in English, I'll teach you how to sew. And I was like, down. And so I worked with this really cool orthopedic surgeon that wanted to swear in English, I guess. And he taught me. And at that time, I spoke pretty decent Spanish, and I had this sort of healthcare background. And there was a medical mission organization that was based in Quito, Ecuador, and they would travel out to these sites and do these medical missions. And so they recruited me to translate. And in that process, I had never been really exposed to the idea of like a short-term mission, volunteerism, these kinds of experiences, right? Like, again, I was sort of focused on the long-term thing. And what I saw, I wasn't super impressed with. So what I saw was a bunch of North American doctors handing out a bunch of amoxicillin. There was a surgeon that was doing what I felt like was some really concrete work, i.e. like taking gallbladders out of folks and like doing like tubal ligations and like things that were like made sense in my mind that are like moving things forward. But what I learned is there was no follow-up program. And I'm like, so you're going to cut these people open and then like, what happens on day 8? And they're like, I don't know, right? And then kind of the more I learned, there was a little girl that came in and she needed heart surgery. And she brought in all the studies that she needed to get heart surgery. And this national director of this organization, this is a multinational nonprofit operating in like 20 different countries, says to this mom, I'm sorry, like, we just don't do that. And I thought to myself, like, how is that the response to the little girl that needs heart surgery? Like, I thought we were here for her, right? And so I thought, that just doesn't seem right. So I kind of saw these things and it was just a little bit frustrating to me. And I was like, there's got to be a better way. Fast forward a little bit, that was it that trip? I guess that trip, there was a Canadian dentist and teacher that had brought down like 50 pounds of books and hats. And they wanted somebody to take it to this school that was near Riobamba. I happened to be working at this hospital in Riobamba. And so I take it to this school. It is insane. It's like a bus ride an hour this way, a pickup ride like 2 hours into the mountains, hiking for like 6 hours that was supposed to be 30 minutes. And like you're in the middle of like a place that there's nothing, right? And this Canadian family had this connection to this school, and I leave the supplies, and the folks in this community are like, hey, is there any way that you could bring back, more supplies, doctors, blah, blah, blah. That's really what started MedLife. So we went home and kind of in frustration of what we had seen, said, is there a way that we could do this better? I will not tell you that we did it better, okay? We had the intention to do it better. We didn't start out better. So we had a North American physician come down and provide care. And it just so happened in that first clinic that we did, we had a little boy that was 3 years old that needed heart surgery. Right? And it's like, there's your karma right there. Right? Criticize somebody for not taking care of the kid that needs heart surgery, we'll send you one. Right? And so I and another guy who is one of the founders of MedLife, who's also an ER doctor, were the first follow-up nurses. Right? So we then had to figure this out. We're like, okay, we're in rural Ecuador. We don't know. Can this kid get surgery? Can he not get surgery? We don't know. And so we just started navigating the system. We figured out, hey, actually there is a cardiac, a pediatric cardiologist in Quito. There is a pediatric cardiothoracic surgeon. And it turns out we were able to get him the care. And it just kind of took some navigating through. And that was really how MedLife started. It's continued, as you've heard us say, we're focused on trying to bring local physicians in, making sure we do follow-up, treating the root causes, stuff like that. But that's how it started. Another question? Yes.
If you had to pick one memory in MedLife to like never forget or to like be your memory of MedLife, like what would it be?
I'd be lying, man. I don't know that, to be honest, this one. I mean, certainly the little boy, his name was Darwin. That will be burned in my brain for a long time because it was. So I think, we were talking today. What is MedLife? And we think about this a lot because we're trying to get more savvy. We're trying to kind of build our audience. We're trying to get more people into this, right? And the conclusion that I've come to is like what MedLife is trying to inspire people in their communities to make a bigger impact, right? And so like for you guys, it sounds like I'm saying that and you're here and it's intended for you. I don't fully mean that. Like it's also intended for me. It's intended for all my staff that's here. All my staff that's here, right? They want to have an impact too. The communities where you are, we work with these folks called dirigentes, right? They are the elected leaders within the communities. They want to have an impact in their communities, right? And I think what MedLife is all about is trying to gain the confidence through problem solving and tackling small problems to then have the confidence to go on and tackle the next problem. Darwin, for me, taught me that I could do this in a much bigger way. He taught me that I could do follow-up, that I could get a kid in rural Ecuador heart surgery, that I could get follow-up done in a really complex way. It gave me the confidence to kind of dare to believe that this future might be possible someday. Does that make sense? And like that, there's been multiple experiences where then, you know, the next kid happens, and then the next thing happens, and then the next challenge happens. And it's all just kind of this sequential step of building your confidence over time, tackling more and more challenging problems. But in many ways, that was the problem that I had to solve initially, you know. So I would say that'd be probably one of them. Yeah.
Do you have any advice for us going to medical school?
Yeah. Cool. Yes. Let's think. Advice. Okay. So if you guys, you're obviously all coming here. How many of you been to Lima, Peru before? Nobody. Perfect. One. Okay. If I was going into a new emergency room where I haven't been, I would want people there that understood where to send the heart attacks, right? I would want somebody there that knew which surgeon's on call for the appendicitis. I would want somebody there that knew who to call when the sick pediatric kid came in, because I'm not from there. Even if I'm still working in the United States, even if I'm still operating in the same places where I work, just because I don't understand how that system works, I would want somebody who had been there to understand how to navigate that system. Fair? Right. So the idea, the concept that anybody could come to a place like Lima, Peru in 7 days and operate in any way that's efficient without a Peruvian physician sitting beside them is insane, right? I would not do that in Texas, right, where I've been practicing for the last 8 years. I would not do that in any part of the United States. I would say, hey, there's got to be somebody that can kind of orient me to this process, right? And yet when we do global health, we kind of have this concept that like I can fly in, bang out whatever, and then kind of ignore the local system, ignore the local docs, not have a follow-up plan, not have a plan to screen patients or do tests, and somehow I'm going to be effective, right? It doesn't really make sense. We wouldn't do that in our own cultures. Do you know what I mean? So I think one is understanding that to be effective, you got to understand the system that you're working in, and you got to understand how to navigate that system. Right? And that's true anywhere. There's probably a lot of things we could talk about in terms of thinking about being a physician, but yeah, we'll start there. Yeah.
Comment a little bit already, but what are your overarching
Yeah.
goals?
Yeah. So when I was training, there was a guy, Jim Kim, who was one of the founders and Paul Farmer of this organization that brought me to Lima, Peru. And they believed that we needed a new discipline in the United States called healthcare delivery sciences. The magic of the universe, I happened to be at the university where Jim Kim then became the president and implemented the first masters in healthcare delivery sciences. Right? They strongly believed that the problem was so big that it wasn't a matter of having a great NGO or having great funding, but they needed to have lots of people addressing this issue, and we needed to get educated, and we needed to push the field farther than it was right now because the problem was too big. I think in short, that's kind of my hope, right? I don't hope to do that in isolation. I don't come here to like inspire you guys to do this career and do nothing for the communities that we're serving. I hope to inspire you to take that next step and get really good at it. You can learn how to do this work in a theoretical vacuum. I think you learn this work through doing it and through failing and through trying and then, right? And so I think that that's my hope, is that we can push the service that we provide to the communities that we serve farther, bigger. The huge hole you've seen in the side of the mountain, you know what I'm talking about? You walked like by a huge hole going up to the park. Yes, that's intended to be a school. We have architectural plans drawn out. We have engineers proving that. Like, we have some modular housing stuff that we're working on to try and improve modular housing. I'd love to see like more ophthalmology in our SLTs. I'd love to see some ultrasound screening tests. I'd like to see us pushing farther, kind of how far we can take this, but then also pushing you guys to get really good at this too. You know what I mean? Because I think we have a long way to go. Like, we have a long way to go. Yeah.
What were some of the biggest obstacles you faced when starting up?
Yeah. Well, so if you're going to go to med school, you probably shouldn't start an NGO at the same time. Just FYI, like not a good idea, right? Like there's this world of what we're talking about and doing and stuff, and then there's like administration and payroll and insurance and like it's just like this whole world that you don't even pay attention to and think about in terms. You don't need to go that path, right? And I was just naive and I didn't know, and so I did. If I was in your shoes now, if my son wants to go to med school, I'd be like, go to med school. Just focus on med school right now, right? So I think that the element that is trying to run an organization is not easy. I mean, the leadership skills, how you mentor young people, not just yourselves, but our team, like those are some really challenging things. In terms of the community side, probably so there's a saying, I don't remember where from, that nobody minds that the fish are wet because the nature of being a fish is to be wet. And it's in the context of that quote was that nobody minds like poor people suffering, basically, right? So if the standard of care for people living in Pamplona Alta is whatever, poor OB care, no OB care, dying of a heart attack when you don't have to die of a heart attack. If that's the standard, they are all accustomed to that being the standard. And to try and break that mentally is really tough, right? Because everybody's kind of coming at the framework, well, this is just the way this is, right? I mean, if any of you had a heart attack right now, we would be whisking you off to the biggest, best hospital that we could. That doesn't happen there for most people, right? Like there's this divide of this is how we treat people that look like this, and this is how we treat people that look like that, right? And trying to break that in our own minds and the minds of our patients is tough. It's not easy because it's so baked into the way that everybody grew up, That is a big, big challenge. COVID was an insane challenge. I mean, that was just like shifted from what we're doing today to like soup kitchen overnight. And yeah, that was crazy for a while. Those are the things that come to my mind in terms of big challenges. Yes.
I know we have
Yep. Yep.
Do you have any other things you want to try to go to?
Yeah, I mean, it comes up often. Is there a location that you want to go to? No? Okay, all right, no, it's okay. Oftentimes somebody asks that question and they're like, because I would come from this place. Yes, I mean, there's a lot of places we have relationships with folks in different places. To be honest, building the audience and the service side is much bigger challenge than that. That, like, we could do all day long in a whole lot of places. I think that from the service side, that's really easy. From the you guys side, I think it's providing value to you too, and going to places that you can really learn, right? I think so. That's kind of the things that we think about. We're working on Guatemala right now, but we've also visited South Africa. We spent some time in Kenya a long time ago, India, Nepal. I don't know that that'll happen, but yeah. Yes. Building the audience, to be honest, like getting more people involved, you know what I mean? I think that the global north is in population so small to the global south, the scale. So when you're in, it's harder at this time of year, but when you've been at the Union Santa Fe Park that you guys are working on? Yeah. So when you look this way and then you look this way, there's just hill after hill after hill after hill, right? It doesn't ever end. And that goes for, I don't know, somebody correct me on my team, 50 kilometers that way and 50 kilometers this way. And that's just one part of Lima, Peru, right? And Lima, Peru is not even the worst resource place in Peru, right? You have all these places in Peru, and then you have all these places in the rest of the world. So like the scale is a scale to which I don't think we can really comprehend. You know what I mean? Like it's so much bigger than the scale of this. That, to be honest, I think is one of the biggest challenges. I think also communicating the message is also really hard, And so I wasn't very good at that. I was sort of saying to folks, like I had this attitude that like the only thing that mattered was getting the kid heart surgery. And so I was very stubborn about this. I was like, the students don't like their sandwiches. I'm like, I don't care. That's not why they're here, right? And we need you to do this with marketing. I was like, nope, right? Like I was just very like hard-headed, like I am here to take care of this kid. And I've learned over time that you don't get much done doing that. Like you got to do this too. So I've kind of come around a little bit in terms of like message is really important. Yes.
In light of like scale of poverty,
Yes.
both in Peru but globally, the scale of like injustice in general, how do you keep hopeful and motivated?
Yeah. Awesome. Wonderful question. So, so how many of you again want to work in healthcare? Cool. So I want you to project yourself now into the future. You are this healthcare provider, nurse, NP, physician, right? You are now at the bedside of a patient. That patient is having a heart attack. What is your primary concern? What? Save her life. Okay. Are you worried about the rest of, quote, the world in that moment? No. You can only solve one problem at a time, maybe a few if you're really smart and talented, right? And I think that the narrative we have created, which is a false narrative, is that we have to somehow address the world's suffering. And the reality is you just got to choose a community and serve that community. This is my community. An hour and a half outside of Houston, that is my community. That is where I serve. I can't serve in India at the same time, right? I can serve you tonight, I can serve you now, but I can't serve, quote, the rest of the world. And so if somebody says to you, like, how are you going to take care of the world? The problem's too big. They're presenting a falsehood to you, right? No one has ever said that to you. Does anyone ever say to you, if you want to become a physician, how are you going to take care of every patient in the United States? Does anyone ever say that to you? No, never. The only time that you're presented with the concept of desesperación, hopelessness, is in treating the poor, right? That is the only time. If anyone ever says like, hey, how are you going to take care of the entire United States? You're not doing enough. You're like, bro, I'm a doctor. Like I'm taking one patient at a time, right? But somehow when it comes to Peru, all of a sudden you're not doing enough. You got to do everything, right? And so I think if you choose Lima, Peru, cool, we'll hang. If you choose Western Maine, down East Maine, or West Virginia, or I don't know, the Bronx, then that's the community you serve, right? I think that one of the really cool things about MedLife is that we develop community around some of these ideas. And so the way that I approach serving my community here and in Texas, I can share that approach with you, and you can take that to the Bronx or West Virginia or whatever, right? And so that's part of the great part of MedLife in terms of having this community. I have no expectations that you're coming to Lima, Peru to somehow help me in the communities I've chosen to serve. But if I can help you have the same approach for your community, then we're talking, right? Does that make sense? Good questions. Yes. Yeah. Yeah, to be honest, it's not very hard. I mean, it's just like recruiting any other like position that we hire. We just put out kind of job, not applications, but recruiting stuff and different websites and stuff. A lot of it now we know people and we're kind of in communities, and so we don't have to kind of use Indeed.com or something like that. Like, you know what I mean? We're part of those communities, and we can kind of go to the same folks. So, yeah. Yes. Yeah. Yeah. So there's tons of lessons there, right? So the question was like, what would you like young health providers to learn to try and close gaps? So let's see. I think in the United States, we talk a lot about equal access to services, right? Like everybody deserves equal access to a physician. Fair? Like, do we talk about that? I'm not saying that we do it, but we talk about it, right? I think we talk much less about the idea of equal access to outcome, right? the fact that you are here on your summer break, whether you feel privileged or not, means there is a fair bit of privilege in your life. Okay? Sorry. Lost my train of thought. And I think sort of how we approach global health, and we have to kind of treat it similarly to how we treat our own lives. So like, let me ask you this question. And we've kind of talked about this, a few people already, but if you're, well, let me start here. How many people feel that sustainability is important in global health? Can you raise your hand if you think it is? Okay. And can somebody define sustainability to me? What does that mean? Global health sustainability. Yes.
I would just say that we have all
Okay. Sure.
Like how you were saying before, even random urban American doctors.
Yep.
That kind of less than all of whatever they were.
Yes. Somebody else. What is sustainability in global health? Yes.
I think it's also giving the people the education to care like all
Okay. Okay. Great. Excellent. So kind of the theme is like long-term care, right? Okay. So if let's say if something's not sustainable, would you pursue that opportunity? You would not. Okay. So now let's say your grandmother has metastatic cancer. Is it sustainable to provide her with chemotherapy from a financial perspective? Let's say that costs $100,000. Is that a sustainable practice? No. So would you let your grandmother die without chemotherapy? What? No, you would not. Anybody else? Grandma dies? Yes or no? You gotta put your stake in the ground. All the sustainability folks. Yes or no? Grandma dies? Yay. Grandma dies. Screw grandma. Okay, grandma does not die. Hands up. Okay, why does grandma not die if we're so into sustainability? It wasn't sustainable to provide her chemotherapy. She's old. She's got metastatic cancer. She's gonna die. We're hardcore sustainability folks, right? Grandma should be dead. She should be dead. Fair? So is sustainability the golden rule in your family? So what rule do you follow in your family? Is it ethical to let grandma die without chemotherapy? Not very ethical. Arguably sustainable. Was slavery sustainable? Was slavery sustainable? I think you can make the argument, yes. Was it ethical? No. Everything that's sustainable doesn't mean it's good, right? So I think coming back to this question of like, what do I want from you guys? Like, I want you guys to treat poor patients the same way you treat grandma. If you are going to break the law of sustainability for your family, then don't apply it to the weakest, poorest, sickest people in the world. Make sense? That is not to say that sustainability is not important. That is not to say that MedLife is not working very hard to make things sustainable. We believe in that. But what we don't believe is that sustainability is the reason to deny people care. And I will tell you, after doing this for 20 years, too frequently, when we talk about sustainability, I see it in the context of denying care to somebody. And I think the thing that's cool about sustainability to me is like, this thing is not sustainable. Cool, let's attack this, let's go, right? The medical missions that I saw when I was involved 20 years ago, those were not sustainable things. Awesome, let's go, right? If it's the start of the conversation, let's roll. Like, I'm all about sustainability too. Let's fix this now, right? Let's go, right? But a lot of what I hear is that's not sustainable, so we stopped, right? And who gets hurt in the global world of poverty when we, the people that control the resources, say, I'm sorry, that's not sustainable. I crossed the line here. Grandma, go to the hospital. But for you, I'm sorry, you Peruvians, you low-income people, chemotherapy for you when you got metastatic cancer, Does that feel right to you? No, right? So sustainability, right? When you hear someone bringing up sustainability, is it a force of motivation to make things better, not a reason or an excuse to deny people care? Make sense? So the next time you say to somebody, hey, that's not sustainable, be like, cool, what are you doing about it? And see what they say, right? If they say, oh, I quit, well, there you go. There's your answer, right? So how many people feel like voluntourism or a 7-day trip is sustainable? Does it have value? Is it ethical? Questions to make me think, right? I will tell you, like, so in Lima, Peru, when I came here with an organization called Partners in Health that was doing multi-drug resistant TB work. At that time, what happened basically was there was a priest, a Catholic priest from Boston, Irish guy, who got TB and passed away. And so a bunch of these doctors were like, whoa, what's going on? Like, TB is supposed to be this bacterial infection. You treat it with antibiotics and you get better. So, like, I don't understand. Like, he got the antibiotics, but he passed away. What's going on? And so these docs from Boston start getting interested in the northern cone of Lima, Peru, and they start figuring out, there's all these folks that are getting treated for TB, but they're not getting cured. What's going on? And it turns out that they had been taking so many antibiotics that they developed these multi-drug resistant strains of tuberculosis, and they weren't getting cured. So everybody's like, whoa, that's kind of scary. Airborne disease that is multi-drug resistant. I don't know if you saw a couple years ago, there was a guy, a lawyer from, I don't know, somewhere in the States that had multi-drug resistant TB, and he was on an airplane. Of course, everybody freaked out, right? At that time, when that was happening, what do you think the response of kind of global physicians were when they heard about this new strand of tuberculosis that's coming out in the world, this multi-drug resistant scary infection? What do you think the response was? Take a guess. Yay or nay? So the response was, that is not a sustainable thing. The world cannot provide care to all of these people who have multi-drug resistant TB. Right? If you have the opportunity, watch the movie Bend the Arc. Wonderful movie, was on Netflix. I don't think it is anymore. I don't know where you can find it now, I'm sorry. But there's a bunch of books about this guy, Paul Farmer, and basically this organization took it upon themselves to get a private funder, treated 10 patients for $100,000, proved that you could treat multi-drug resistant TB. Lima, Peru became the global center of treating multi-drug resistant TB. And basically, through the World Health Organization, these guys are like titans, right? I mean, like, I'm a joke compared to these guys. I mean, they figure out how to treat multi-drug resistant TB, and then they're like going to the UN to be like, hey, we're gonna do this at a global level, right? But now, globally, multi-drug resistant TB is treated, and it's not something that people say, oh, I'm sorry, that's not sustainable, we can't do it. These guys said, hey, that's not sustainable. Again, watch the movie. Basically, they brought the drug prices down by working with pharmaceutical companies in India to bring down the cost of the medicine, right? So they said, yes, you're right, it's not sustainable. So what are we gonna do about it? And they changed it, right? So I think that's one thing, is like applying. If you're gonna choose to serve low-income people, apply the same rules to those people that you apply to your own life and your own family, right? If you're gonna say that people should die because of sustainability, then have the guts to say it to your own family, right? And if you're not, that's cool, I agree with you. I don't think you should, but then let's not deny people care because of that reason. Let's get motivated and be like, yo, this is not sustainable, we need to fix this. Make sense? So we don't deny people care because of sustainability. We get motivated and we fight through it, right? Make sense? Okay. Second thing, I think that I had started was with the equal access to outcomes. So I am 44 years old. I have a very strong history of heart disease. On my dad's side, everybody had a heart attack. I think it's coming my way. I hope not. I'm on the right medicines, right? But if I have a heart attack, right? I'm educated, I've got insurance, I've got access to food, I've got a warm house, I've got a family, I've got all the resources to pull me through that, right? If somebody has a heart attack in Pamplona, right, where you guys have been spending time now, they don't necessarily have a warm home. right? They don't have food. They don't necessarily have medical insurance. They don't know where to go. They don't have the same education that I do. They don't know what they need for treatment, right? So you can say that that person had equal access to the service, but they don't necessarily have equal access to the outcome, right? And if, as a physician, right, I don't say, hey, lady from Nicaragua, you're from Nicaragua, so we're okay if you lose the pregnancy. And hey, lady from Houston, I'm not okay if you lose your pregnancy. I look at you and I'm like, you are a human being. I don't care if you're from Houston, Nicaragua, or where you're from. My goal is to get this pregnancy through and you have a baby, right? Is it possible then the resources I would have to provide to the Nicaraguan mom are different than to the Houston mom? Totally. Do we do that in the United States? No, we do not. So if somebody doesn't have access to transportation, do we help them get access to transportation? Sort of, maybe. Do we have access to food if they don't, right? So I think that the concept is, for us, we're not really worried about equal access to the treatment, right? If I can get a surgeon to open your chest and operate on your heart. But if you die a week later because you didn't have food and you didn't have a shower and you didn't have somebody to change your bandages and you didn't know that when you had a fever to 103, that meant you had a post-operative infection, that didn't do you any good, right? And so there's this concept that we were talking about earlier that actually has come out of the northern cone of Peru from a guy named Gutierrez that's now at Notre Dame. And the basic tenet of the idea was that if somebody's low income or has low education, you have to give them more resources to get the same outcome, right? So people with fewer resources get more attention because they have that. That is not how we operate, right? We operate on, you have the same access. And then, I mean, to be honest, as a physician, like, we ridicule the patients that don't have the education and resources. We're like, they're non-compliant, they don't take their medicines, blah, blah, blah. When the people with resources do take their medicines, they understand, they have the resources, right? So I think those two things, I would say, is like, let's make sure that the things that we apply to the poorest, least educated, most vulnerable populations in the world, we're gonna apply to ourselves as physicians or nurses or nurse practitioners. And then also think about equal access to outcome, not just services. That was long, but those are two. Is that helpful? Yeah.
What is the most valuable constructive criticism that you've received?
Oh my God. You guys have such good questions. Not easy questions. Whew. I mean, one thing we were talking about earlier was, like, there is theory of doing international development and global health, and then there is doing it, right? And the funny thing is the two camps of human beings that study it and the people that do it are not in this, they're not the same human beings, right? They're very different populations. And so I mean, we've just, to be honest, man, we've failed so many times. There's just, I mean, every time you fail, you have to look inwards and be like, what could we have done better, right? So we've lost patience and we've done things and that didn't go the way that we hoped they would go. And I think the harshest criticisms are that, right, is when you had full intention to do the right thing and you tried your hardest but your hardest wasn't good enough and you had to kind of up the ante and give something better. Those are harsh lessons. They're painful lessons. Do you know what I mean? Those are the lessons where you grow the biggest. Those are the reasons that when I tell you equal access to outcome, it's because I learned that, right? I didn't read that. That's not an article I read. That's a failure that I had. Does that make sense? Like, I didn't provide equal access to the services required to get the right outcome, so I lost the patient, right? Those are tough losses. Yep.
I'm just wondering how you would explain why what MedLife does is someone who's selfish and doesn't care what happens.
Yeah. I mean, I'll give you the MDR-TB, because if you ignore it, MDR-TB is coming for you. MDR-TB is an airborne disease. It is now XDR-TB. There are not new antibiotics to treat it, and it is coming. It will be on airplanes. It will walk across the Rio Grande, and it is coming, right? And so I think that's the concept of public health, right? Like, if somebody gets cosmetic surgery, does it affect the rest of the world? Probably not. If really low-income people develop really resistant airborne infections, does that affect the rest of the world? You better be right that does. You know what I mean? And that's scary, man. I mean, as a physician, when you're taking care of patients and you're looking through cultures, so if somebody has TB or if somebody has UTIs, you can look through the culture. Somebody pees in a cup and you grow that on a culture, and then we put antibiotics on a little petri dish and we see, is that organism that's growing out sensitive to an antibiotic? When you get to the place where you have a patient that doesn't have antibiotics available to them, they die. That is a reality already. That is a reality already. I deal with that all the time. I mean, I got a guy that comes into the ER all the time in Texas with multi-drug resistant UTIs, and he is a young guy. He's gonna pass away from a urinary tract infection because he just doesn't have any antibiotics anymore. Now that sucks for him, but you don't have to worry about that. But when it goes airborne, you do, right? And so I think that there are infections and things that we need to be aware of because, from a very selfish perspective, you may not be affected, but your kid is going to be, and to be honest, you may be too. We're seeing more around Houston. We're seeing more and more TB. Like we're getting emails from the public health departments. This person had TB. If you suspect TB, please put an N95 on. Blah 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 blah. And it's like, how do I suspect TB? Like, you know what I mean? Like I get an X-ray and they're like, we suspect TB, and we're like, oh. But by that time, everybody's been in and out of the room 20 times seeing the patient. Does that answer your question? And like that too. I mean, I got to be careful not to wade into really polarizing political things. But I mean, regardless of how you feel about people coming into the United States and immigration, if they can't have a life here that is safe and have health care and education, there is no wall big enough that will stop them. There is no wall big enough. There is nothing you will do to stop a mother of two going north because she can't have a life here that is safe for her children, right? And so I think if we're seeing more and more people roll into our country or Europe, and there's all this conflict in terms of immigration, and a lot of that has to do because they're running away from extreme poverty here, right? And so we can say, hey, that's not my problem, Peru. When they show up in Denver, it is. So I think the reality is we're much more connected than we realize. Other questions? Yeah. How are we doing? Sorry, how are we doing time? Is there basically I saw that there was a demand for an inferior product. I mean, if you want to put it in those terms, right? I mean, is what you want out of doing this to have a positive impact on the communities that we're visiting? Yeah. And if you don't feel like you're having a positive impact, then I just need to make sure that you have a positive impact. And to be honest, it's not that hard. You do follow-up care, you do staircases, the things that we are addressing, and you can do it. I say not that hard. We have 35 staff members that are Peruvian that live here. I live in Peru full time. You have to be committed to it, right? You're not doing it out of Houston. Yeah, basically. Yes, somebody's pointing a hand. Yes. And I just did a post-bac straight up. I just went home and took chemistry. I didn't do a post-bac. A good friend of mine did do a post-bac, worked very well for him, didn't have the GPA to get into med school, and kind of had the realization that I'm not going to become a physician if I don't get my life straight. And he did a formal post-bac with the idea of I got to get the GPA straight now. And now he's a physician. So I think in the right context, if you don't have the GPA you need, a formal post-bac can be a good thing because it's pretty rigorous and it'll get you kind of mentally in a place that you need to be. For me, I just went home and did the classes. But, yeah. Great. Cool. Any other questions? Great. So how's this week going? Yes.
More Houston or Orleans?
Yeah, interesting question. Houston's got better Mexican food. I mean, here, man, I have the benefit of I have a nonprofit, so when there's a patient that's poor, like if we need to build them a house, we build them a house, right? Like I have this flexibility to provide really great care to my patients, and I'm really limited in Houston. Like I see somebody and I'm like, this is an issue, and like I don't have resources available that I can deploy to solve that problem. So that's a little bit frustrating to me. You know what I mean? I wish that I had MedLife resources in Houston that I could like call up and be like, yo, this patient needs follow-up. Go, right? And I don't. And so a lot of folks are lost to follow-up, and you know, there's just a lot of problems kind of getting through the system. Yeah. Cool. So how is this week going? Like, easy peasy, I've seen this before. This is sort of challenging some beliefs and experiences that I've had. My perspective is changing. I already knew that this is what it was going to be like. Like, how are you guys feeling? Yeah.
I feel like it has definitely,
Mhm.
especially because the first time out of the United States, and I've never, you always hear about people who don't have access to certain things, and you always hear about people that are less fortunate than you.
Sure.
But it's not really a true reality until, you know,
Yeah.
and just see, like, for example, people said, like, couldn't go dental because they didn't have a ticket when they, like, really needed it.
Yeah.
Was something that, like, sparks kind of, like, a fire for me. Like, almost makes me, like, mad.
Yeah.
So I feel like it definitely makes me feel passionate about helping people and providing that one-on-one care.
Yeah, that's great. That's great. Yeah. I think a lot of the time, so sometimes we talk about volunteerism and like medical missions, and I think people get all like hyped up on like, you know, is this sustainable? Is it not? Is it ethical? And they want to talk about like these really big ideas. And I have not done this, but I think to myself, like, what was like the initiating experience for Nelson Mandela, right? Like, it's not like he just like did the thing he did, or Mother Teresa. Like, there was a childhood there. There was some experience in young adulthood. Like, there was something that happened that then led to this thing, right? And we kind of ride folks for wanting to have like this initial experience to kind of open your mind and your experience. And I think it's totally misplaced, because I think, how else do you start? Like, you know, had Mother Teresa been told, no, can't do that, like it wouldn't have happened, you know? Like, all of these incredible people in life started out doing something that kind of exposed them to a problem that they then chose to serve. They weren't born that way, right? And I think that, you know, we were talking, some of the interns and I, so we have 2 interns here. So if you want an internship, raise your hands, girls. There you go. Come back and serve with MedLife for 8 weeks or 12 weeks, a while for the summer. We're also working on reactivating the year-long internships. So like if this is something where you're like, I have done 7 of these trips, I am ready for the next thing. Cool. Talk to them, right? If it's your first time, awesome. Come back again, do it again, and then eventually you come on an internship and you do something a little longer. Doesn't have to be with MedLife, you know, you just do it with somebody else. You know? Other folks, how are you feeling about this week? Yeah.
I knew it was really bad coming here, but it was definitely more eye-opening than I thought it would be.
Sure.
But honestly, my respect for
Yeah.
how strong they are, and
Yeah.
how like kids are so happy, but like
Yeah.
here it's sad for us, we're privileged.
Sure.
And oh, it's sad, but they're not sad.
Right.
So there's such a strong
Yeah. Yeah.
And I feel like America, we're over here like, oh no, my nails don't look good. Got
Right,
my nails done.
right.
I'm sad about that.
Yep.
Or something. They're over here like, don't have food. And
Right.
like, we're happy.
Yeah.
Like,
Yeah. Yeah, it kind of challenges your ideas of what happiness is, or like what the end goal is, or like, am I on the right path, right? And I think, you know, more and more, I have little kids, and so I worry about this with like social media and just like being isolated in a room and like these polarizing things coming through this screen and like feeling kind of depressed and isolated. And I don't you know, whether you follow sort of addictions medicine, but there are more and more folks saying that the opposite of addiction isn't sobriety, but the opposite of addiction is connection, right? And so it turns out that a lot of folks that go through addiction and have those issues are very isolated. And as they start to come back and build communities, those communities are able to help break down those addictions, which is fascinating, right? To think that somebody is suffering through addiction because they are isolated and that the solution is greater human connection, right? I mean, it's kind of like a blow your brain moment. And it, you know, the number of folks that I deal with in the emergency room that have addiction issues is pretty high in Texas. I don't know people that are addicted to drugs here. I'm not saying there aren't people, but I don't know them. I don't know anybody that's doing cocaine. I don't know anybody that's doing heroin. My staff that's here, that's Peruvian, look behind you real quick. How many of you guys know somebody that's addicted to heroin? No, yeah, that was California, so that didn't count. And if you know somebody, Nick, in the United States, that's what I'm talking about. In Peru, do you know somebody that's addicted to heroin in Peru? Yeah. Do you know somebody that's addicted to opiates in Peru? Yeah. Do you know somebody that's addicted to cocaine? Maybe. Man, we are a net producer of that. Right? So, but I mean, it's really fascinating to think about, you know, what is the end game here? Like, is the end game like me cranking out shifts and like being isolated and just like having this narrow vision and you know, not having this human connection, or is like the end game like community and family? And I think this is something too that I really love having the professor thing, because I get to like kind of like do the old person thing a little bit, because sometimes you guys are like 22 and you're looking at me like I'm crazy. But we can kind of have these conversations and talk. And I think we as kind of administrators, docs, older folks, like appreciate the idea of community, right? Like, and like we can often feel a little bit isolated. And I don't know if you guys feel that now. Maybe you do, like with all the social media. I don't know. But I think as you progress in your career in service, whatever that is, nursing, doctor, global health, you need to have some community like this that you can do what we're doing right now, because you will hit moments that are so intensely frustrating, sad, losing patients, whatever, that you need to be able to have this to go back onto and kind of reflect and talk about and whatever, you know? Yeah, and so I think that idea of community, I totally agree with you, is really strong here, and it's a wonderful thing. Anybody else? How you feeling? Anybody feeling like very guilty? Yes? Yeah. That's not super uncommon. And sometimes as you go home too, like you may find that like you're like kind of some culture shock type stuff, and you're kind of some guilt feelings, and like, why do I get to have this and these people did not have this, and they were so happy in their families, and I'm sort of depressed, but yet I have the good nails and an iPhone and whatever, and it's like, what's wrong with me, right? I think those are kind of some normal reactions, to be honest. And like the thing that I would encourage you to do is like, that's the cool part of being part of MedLife, is reaching out to the community you are and like talking about those things. You know what I mean? Because I guarantee you it's not an isolated thing. It's not just you thinking that. Like there's a whole bunch of folks trying to make sense of their place in the world and realizing the relative privilege that you have, and then being like, now what do I do? You know, that's part of, I think, of this whole process. Cool. Well, I think we can wrap it up. Any last questions? Maybe one more, or any last people want to share anything? Good? Awesome, guys. Well, thank you very much. I mean, you have lots of opportunities to do with your lives. You could have done a whole lot of things this week, I'm sure, and you chose to take care of some really low-income folks that kind of are down and out despite being happy and connected. And we appreciate it. You know, we couldn't do this without you, and it really makes everything that we do possible. And I can tell you the communities are just again and again, you know, thanking us so much, you know, and they couldn't be more appreciative. So thank you all for everything that you do. It's important.